right, hello everyone. Welcome to this panel discussion on navigating trust in healthcare, human connection in the digital age. My name is Amanda Stuckey, and I'm a principal in the Health Policy and Insights practice at Economist Impact, the think tank and engagement arm of the Economist Group. I'll introduce our truly exceptional panel in just a moment, but before I do, I'd like to ask the audience here in the room a few questions. I know that we're the first panel of the morning, so we'll try to get you going a little bit. So first, please raise your hand if you're wearing some kind of smart health device, like a smartwatch. Great. Interesting. All right. Now raise your hand if you trust your doctor's diagnosis more if you knew that their decisions were AI assisted. Interesting. Okay. Great, now a little bit trickier. Please raise your hand if you would trust AI with your most sensitive health data for the sake of medical progress. Slightly fewer. Okay, thank you. Very interesting. Keep your answers in mind during today's panel as we'll revisit this at the end of the session. To give a bit of context to this discussion, within a backdrop of rapidly evolving technology, geopolitical conflict, intensifying climate impacts, and high uncertainty, trust is of utmost importance. We've heard that a lot across the conference so far. In healthcare, trust is a key success factor as it's fundamentally a human-to-human endeavor enabled by digitalization, artificial intelligence, and new technologies. Patients entrust their health and sometimes their entire lives to healthcare facilities. To integrate new technologies and treatment methods into clinical practice effectively, clinicians must build and maintain trust. I think we can all agree about the collective need to promote trust at the center of healthcare systems' pursuit of technology and progress. In this session, we'll explore the delicate balance between these technological advancements and the essential human elements of healthcare, and discuss the impact this has to ultimately foster global health for all. I'm excited about the distinguished panel joining me today, which I'll introduce now. First, we have Dr. Alain Lebrique, Director of the Department of Digital Health and Innovation at the WHO. Mr. Michael Sen, CEO of Fresenius Group. Dr. Karen DeSalvo, Chief Health Officer at Google. Ms. Marlies Gergens, Lead Program on Digital and AI for Human Capital at the World Bank. And Professor and Dr. Liam Smith, Director at the London School of Hygiene and Tropical Medicine. All right, so let's get into it. Alain, I'd like to start with you. WHO announced last year the Global Initiative on Digital Health, aiming to support member countries to scale programs and pilots up to well-functioning digital health infrastructure. More recently, it's published a vision for cultivating an AI ecosystem for advancement of safety, equity, and progress on SDGs. What are some of the motivations behind these initiatives, and how can we ensure equitable access to advanced healthcare technologies across different socioeconomic groups and geographic regions as we scale them up?
Thanks, Amanda, and thanks to everyone for joining us here this morning. These are really important questions and important topics that the fact that the World Health Summit has now focused on digital health and digital transformation as a key theme for, I think, 3 years in a row speaks to the importance of this area. I think many of us in global health are impatient optimists, right? We want to see things move faster to accelerate change. And I've been a researcher in global health and especially digital health now for almost 20 years. I had the privilege of conducting large-scale randomized trials, testing the efficacy of digital interventions on saving newborn lives in places like rural Bangladesh. And we've seen that these systems can, if implemented correctly, save lives. They are also, in many instances, there's a wide evidence base around interventions like telemedicine that now for over 40 years have been used in communities all across the globe, from Canada to rural Tanzania, where these solutions in isolation have been shown to be effective strategies of improving health. But I think, the other thing, in addition to being impatient optimists, many of us have been fighting the pernicious disease of pilotitis. And this sort of donor-driven investment in digital playthings, in digital experimentation, without really helping countries undertake digital transformation. So if we think about this for a minute, there's 20 plus years now of frustration around the fact that we've been investing billions of dollars into digital initiatives, but we haven't seen the kind of transformation that in many countries those investments have been hoping for. So let's take a look at global health. 17% of SDGs are on track. Only 17%. So we've got a work cut out for us. We have 2.6 billion people on the planet who are still unconnected. So in light of this, despite these sort of challenges, we've seen how digital has transformed other sectors. We've seen it transform finance. We've seen it transform banking, education. The pandemic was a big wake-up call because digital was such a key part of the response to the pandemic. And countries that had the architecture, that had the infrastructure in place to respond to the pandemic, leveraging digital, actually fared better. And this was something that came out in a report from the World Bank, that digital capacity, that digital readiness translated into more than just responsiveness to the pandemic. It translated, once again, to saving lives. And so I think that's the context that we're looking at. WHO in 2019 published guidelines for countries looking to strengthen their health systems in terms of at least 10 things they could invest in comfortably to strengthen their health systems using digital investments. So we look across our member states. I have the dubious challenge of supporting 194 countries in applying digital to accelerating their health sector goals. And 120 of those countries have a expressed digital health strategy. Sorry, 129, I was just reminded this morning. 129 of those countries. And many of those countries are actually shifting from having just a strategy to investing in digital public infrastructure. So the backbone systems that are needed for all of the digital experiments to actually succeed. But more importantly, we're seeing countries now investing in governance. So countries like Indonesia, countries like India, Rwanda, having explicit agencies who are tasked with stewarding digital transformation in their country. And this is, I think, the fundamental building block of trust. When we were talking today about sort of this theme of how do we trust our systems to work, how do we trust the systems to be safe and to be effective, the key to that trust is having strong, robust governance. And so what WHO is really trying to do is say, can we help countries learn from each other, put together the building blocks of governance, architecture, and infrastructure that are needed to curate a safe and effective and cost-effective environment where digital solutions can actually save lives and impact health journeys of people.
Great, thank you. And I really like what you said about trust there. I think, in other words, to ask for trust, you have to be trustworthy. I think it's extremely important. Great. I'd like to turn to you now, Michael, as I think you'll have a really interesting perspective here. Fresenius is uniquely positioned as a global healthcare company. You operate hospitals that serve 26 million patients a year. You manufacture medicines, clinical nutrition, medical technology for 450 million people a year. This allows you to cover a broad spectrum of the healthcare industry. In your view, how can AI and digitalization become game changers for this industry, and particularly with the lens of securing health equity?
Yeah, thank you. Look, this is a very exciting time because all of these things are happening as we speak. Digitization for quite a while, but AI is really picking up speed. And let me represent the perspective of the private sector. And as you said, we have our own system, the largest hospital chain in Europe. By the same token, we are catering essential and life-saving medicine and technology all over the world. AI undoubtedly is a game changer. It changes the way how we innovate, how we create, how we collaborate. It will change the way how we learn. It will change the way how we govern. And obviously, it will also change the way how we save people's lives and improve people's life. In fact, I would say we are at a Promethean moment where AI is such a disruptive force, which is comparable to, the printing machine, the emergence of electricity, personal computers, or the internet. The only question is, how will it change? And I'm going to make a statement that probably all of us on what we say today, we're going to be flat out wrong in a couple of years. It's there, it's going to change everything massively, but probably in different ways than we think. The only thing which we can say, I would say we probably underestimate the short-term impact and maybe overestimate the long-term impact when I hear the things that the machine is taking over human mankind and so on and so forth. Now, being a global healthcare company, we have a strategy. And at the core of our strategy is actually the patient, and we say whatever we do, what will prevail, what will not change, is the human-to-human interface, human to human. This will prevail. And whatever we do, because when you take hospitals or when you take life-saving drugs, it's all about trust. So this is at the core of our mission of what we do. Now AI comes in, and AI will obviously have tremendous effects also on our strategy, and therefore we are focusing on three things. And to make it a little more provocative, I would say AI has the potential to supercharge high-quality healthcare. Whether it is on, for example, drugs and all the research, where it can really drive the time, the speed. It is in essence a disruptive force, but it's also a tool. Or whether it is on care delivery. So it will be very much a disruptive force, providing high quality healthcare. We see speeding up the development of medicine. We focus on trends like biology. We focus on trends in cell and gene therapy, for example. We focus on trends of applying robotics in surgery. All of that is getting a quantum leap by AI. When you think about drug discovery, that can speed up things. Even developing vital medicine, smaller companies may be able to reduce the amount and effort for clinical studies to provide, again, medicine for the world. But also, when we talk about care delivery in our hospital space, it will improve clinical outcome. The decision making will be what we have been dreaming about, precision medicine, personalized medicine. All of that is doable with AI. And within our company, we are using and testing AI. AI, when we talk about machine learning, has been there for quite a couple of years. Machines have been trained. So when we talk about diagnosis or screening, whether it's in the radiology department or whether it's on colonoscopy, this is supported by AI. When you walk into one of our hospitals in Spain, when we talk about the first conversation a family has with the doctor, the whole transcript, we use ambient listening technology from technology companies. So we have in a comfortable setting, the patient, the family who may have a serious indication, in a comfortable way talks, and then AI helps transcribe everything automatically. When we think about that medical professionals, doctors, nurses, and other professionals need to focus more on the patient. 3 to 4 hours a day in the Western world, they are busy in writing discharge letters. We now have an application that a discharge letter is being written, and in 2 versions, one for the doctor and one for the patient in a different kind of language, which is more comprehensible. And we have in Spain a huge, I would say, digital and data platform, which we developed ourselves, which is called Cassiopeia. And sometimes I even have a hard time describing what it is. Is it because for patients, it is something to interact with a hospital, with the clinics, but not only hospitals, also outpatient. How can we manage a health population? For doctors, it's an expert system. So number one, it will supercharge high quality care and health. The second thing, and there I deliberately choose the words potentially, it can be potentially be an equalizer for health equity. Us providing generics, IV generics in highly specialized areas, obviously health equity is also at the core of our strategy. So it could supercharge that one because it, as I said, clinical studies for smaller companies are doable. By the same token, and we all know here that the spend on healthcare system is enormous. You know, going forward, you know, the projections are, you two are the experts, 10% of GDP globally, which is 12 trillion. So we have the obligation to spend that wisely. And technology and AI is a means to really be more efficient on that one. And within healthcare, it's not about efficiency like we heard in finance and in other industries. It's also improving the quality and the outcome of healthcare. This is why I think currently the most dollars, investment dollars, sector-wise go into healthcare on AI opposed to other sectors. So health equity can be improved also by that one. I can give you an example in our case. Again, in Spain, we have a day clinic on oncology, and this is a serious disease, as we all know. And with the use of technology, digitization, process optimization, and now AI, we've been able to reduce waiting times, to take away pain from patients, to increase the efficiency. It went from 3 hours over 10 days to 2 hours in 1 day. We doubled the patient throughput. We reduced the time of unnecessary admission, readmission on side effects, and this is all measurable. But I said potentially. I think there's one thing which we all have to keep in mind because we are only at the beginning of this thing, and this is how we collaborate with one another. It changes the way in an ecosystem how we collaborate. Who is actually the one who you trust? Because a hospital or a care provider will work together with big tech, will work together in a government framework. So we need to change the way how we operate, how we collaborate. And there's one thing we have to keep in mind when we talk about health equity. The limiting factors of AI today are, first of all, highly qualified people who really have a clue on AI. The second is energy. It is highly costly to build exactly that infrastructure. First of all, the infrastructure. It is probably costs us a fortune, or only, again, the big ones can afford it, to come up with a foundational model on AI. The first foundational models were 100 million. You know, there are studies out there, the next one is 1 billion, is 10 billion. So who can afford this? The amount of energy which is being consumed, studies out there, the energy until 2030 will increase by 160%. We also have other SDGs, which we also have to take care about. So mind the gap here, as excited as I am. We have to talk about these 3 things. And the third thing is obviously trust. As I said, this is at the core of what we do, and therefore I believe institutions like us will have to play a very important role because patients today come to us and entrust us with the most valuable thing they have, their health, and their life at the most vulnerable moment, when they're sick. So there is an embedded, built-in element of trust in our institutions, and we still have to live up to that. So our strategy, again, is we're building on us being an institution like that. We're building on us having the expertise. We have the doctors, we have the nurses, we have the pharmacists, we have the nutrition expert. And the third thing is that we can apply it. If we, as an institution, can prove that by applying this one, we can really increase clinical output and be more efficient, maybe we will be the lighthouses together in an ecosystem to prove how it's going to work.
Absolutely, thank you. And I think, between Alain's comments and all of the great data that you just referenced, we have a really nice picture of the fact that we're in a really unique moment. And to pick up on some of what you're saying, Karen, on the other side of this coin, we have to ensure that trust is there among the stakeholders that are meant to use this technology. You've said that building trust, particularly with patients, is job one. Part of building trust includes access to trustworthy health information, which is something that you're quite focused on in your role at Google. How can healthcare systems build trust with patients in a digital age where misinformation and disinformation proliferate, especially on search and social media platforms?
Thanks, Amanda. I like to say that health moves at the speed of trust. And I learned that at practicing medicine, that you can be the smartest doctor in the world, but if your patients don't trust you to be on their health journey with them, it's not going to do what you want for them. And that trust is built in all those moments where you are listening, where you are contextualizing, understanding the dynamics in their family, understanding the challenges they're having, finding the best bus route to go visit their kid or take care of their parent. All of those non-medical drivers of health actually also matter a great deal to them. There's a reason why that's such a significant portion of people's health outcomes. And so my patients taught me that they wanted to have that human connection just as much as they wanted the clinical connection. I think I really learned this, though, in 2005 when Hurricane Katrina slammed into the Gulf Coast of the US. I was in New Orleans, that's where I practiced, and took care of low-resource community. My patients didn't have, in some cases, the means to evacuate or needed to come back because they couldn't afford to stay away. So we were on a journey pretty early of trying to make sure they could get connected to the care they needed, but also on a journey of trying to think about how to rebuild a better health system that would serve their needs, whether they were physically present in the clinic with me or their doctor, or if they could do some things remotely. And two huge lessons for me following that storm. One was I needed to get smarter about what they were actually facing every day in their lives. I thought I knew, but I was learning that as they came into my clinic or my hospital and explained it to me. When the storm happened, there were no clinics or hospitals, so we were on the street. In the neighborhoods where people were living, learning, working, and playing or attempting to, and the reality of being in community with people and really beginning to actually see and understand what was happening in their daily lives completely shifted the way that I thought about how I should be building health systems for them, how I should care for them. And I'd like to think that it helped build more trust between me and my patients because I really understood better where they were coming from. The second thing that I learned was that doing all of that human to human, all that care, was inefficient, especially for them, because they had real lives happening, and sometimes it would be more efficient for them if they could just email me. Email was pretty new in 2005, or if they could call, or if we could do telehealth. Or if, especially, we had a digital record of their care so that they didn't have to repeat it every time they came into the system, especially if they went to a different system. So that second bucket was, how do we use technology, essentially, to create the story of their health with their consent and permission that would be able to go with them wherever they went, and they didn't have to first waste time repeating it, and secondly, that they didn't have to waste any of their energy, time, resources always coming into the system, that we could begin to meet them where they were. Carry all that forward to today, and it is all of their faces that I see every day in this job that I do. And it is the replication of those faces all around the world of the people that we think about serving. Because I know also, something I learned when I came to Google, is that I was seeing a lot of healthcare through the lens of a doctor. That's how I was trained. That's how I practiced. What is also happening every minute of every day is that there are people all over the world, no matter where they live, who don't have access to a clinician, period, who don't have one that's a neighbor or a friend that they can just call and ask a question. So they start online. They start online looking up the answers to their health questions. I bet every single person in this room has done that. I've done that. And you want to understand something that may sound straightforward, like diabetes or mental health, or something really complicated that you may have not heard of before. Knowing that, and knowing that at some point they may get into healthcare. We know, for example, even in high-income countries, that 40% of people who are starting online for their searches stop there and don't actually go into care. That responsibility feels big to me and to the team. And so what we want to do is lift up high-quality information on any of the platforms we have, like search or YouTube. And we want to encourage the whole ecosystem to do that. We use public health principles for communication as we do it. We learned a lot of this during COVID. And we've learned a lot of this working with partners like the WHO, where we want to push forward high-quality videos that are recognized by, for example, in the UK, the NHS says this is a high-quality video of content of information. It's not that Google says it is, it's that a trusted entity in where you live is saying that this is high quality. We have ways that we actually use AI to push forward what we call health shelves to get more of that high quality information coming in front of folks. And again, not because we say it is, but because we've worked with the National Academy of Medicine, with the World Health Organization, with local governments to figure out what does high quality mean there, and to have that labeling so that people have something trusted that they can see. We can do that with licensed clinicians and with other credible organizations around the world. We also do things like make knowledge panels, which in its simplest form is basically like a pamphlet, where if you search on diabetes, it pushes that forward onto the screen. And again, it's not what Google says is high quality, it's what the World Health Organization says is high quality, and we want to really push that information up. And where misinformation is harmful, we will pull that off of the surfaces. We have rules and laws around that we follow, but we also know there's a lot of gray in between of where the science is still evolving. That's why we count on partners to help us know how to curate that information. And maybe just to say one final thing about information is that we think a lot about some of the life and death things that people are searching on every day. Is that we don't want to always respond to the query, to the question that somebody has if they want to harm themselves, for example. We want to interrupt that and put forward what we call a big one box that will give them the number to call or the texting line to get help if they are in distress, and we have a set of conditions, including suicidality, domestic violence, where we work to actually interrupt what it is they're asking for. So that's a high level of how we think about information, because we also know information is a determinant of health. We wrote about that last year for the WHS, and you can see the through line. We've got a paper in Nature if anybody's interested in sort of thinking about how we've connected that as basically a kind of social determinant of health. I want to make one more bucket that's not directly in information but is related, meaning like not online information, but the way people receive information in the clinical environment. I think, you know, as I said, starting back in my experience, 2005-ish, it's a long time ago. I can't even do math this morning or this evening or whatever time it is for me. Is that how many years is that?
19.
19 years ago. Thank you. We were the world was starting to use digital tools in the clinical environment. And I am, by the way, really excited about the global movement we have now, which is really focused on governance and about putting people first. The technology is an aid and an assist. It's outcomes and people. So really excited to see this next wave that's happening. But I'd say that part of this wave that is also exciting is that there's new tools in the toolbox. And those tools include this new generation of AI, which has exciting capabilities. It's got a lot of promise, but it also has challenges still. I think making sure that it is appropriately constrained, that it's improved in factuality, that it's improved in grounding. What is the source of that answer that it's getting? We have a lot of work happening in that space, which I could talk about if folks are interested. But I just want to kind of make this point about a paper that was published in Nature Medicine from a university here in Germany, the Maximus University, I'm going to mess up, Würzburg, I think that's correct. And what's interesting about the paper is that they had essentially crafted answers to patients' questions. And they had physicians do that. And then they, in a blinded fashion, showed the same response to patients and said to one group of patients, your doctor answered these questions, a human did. The second group, they said it was a human plus AI. And in the third group, they said it's just AI. Show of hands who thinks that people trusted just the AI more than the doctor in a blinded fashion. I'm happy to say you're wrong, and because they knew, so this is about perception. People in that study knew that AI was involved, and they trusted the human answer better, even though it was exactly the same answer. They were just told something different about how AI was involved. When you completely blind the answers, this is now work we've done at Google, and you don't tell people AI was involved or not, people find the AI to be more informative and more empathetic. So there is a perception and trust issue that is real. It's been, we're documenting that behind the scenes, AI actually really is helpful and perceived by patients better. It doesn't get tired, by the way, so it can answer the same question over and over again. On the other hand, it's better when there's a human in the loop. That's important. But it's also true that if you tell people AI is involved, that worries and bothers them. So no matter what we might think about the power and potential of digital technology or AI tooling to extend care to people all over the planet in a way that's high quality and affordable and is going to give them more contextualized, culturally appropriate information, there's a reality that people don't really trust that technology. And I guess as a physician, sort of going back to the beginning, that does give me some comfort because again, you can be really smart and great, but I think there's something, and AI can do that, but there's something really powerful about that human connection and the knowing somebody in a way that's not just knowing what their pixels are, but actually having that presence and knowing their context and knowing their fears and dreams as a part of the care experience. So I would say from a trust standpoint, information being an important determinant of health, we also can't just think that that's all going to be a digital solution. I do hope that it's going to be an and of humans and digital. Thank you.
Great, thanks, Karen. A lot of powerful examples in what you've said. Thank you. So, Marlies, thinking about the bigger picture here, a lot of the themes that we've heard really point us to the fact that one of the factors influencing patient trust in advanced technologies is separating the hype from the pragmatism. You've referenced that there is hope beyond the hype, particularly for developing countries. So what are the potential implications of widespread technology and AI and adoption in healthcare, and particularly in areas such as workforce and financial burden on patients and on the health system?
Thanks, Amanda. Great question. The first thing I would say is that I agree, Michael, that we are at a unique moment in time, but I think we would also agree that it's not the first time that we're at a unique moment in time. And sometimes it helps to look back. The technology historian Michael Kranzberg wrote a paper in 1986 based on the desktop computer and what had been learned about technology adoption at that time. He penned 6 laws of technology. I won't bore you with all 6 laws, but the first one says that technology is neither good nor bad, and it is never neutral. And really what he was saying with that is that we have to see technology in its context. It is incredibly important that we continuously, as we roll out technology, think about the long and short-term results and measure them, that we think about the potential of what could be and what was actually achieved in the field, that we continuously test and evaluate technology in the context in which it is being implemented. In other words, and I think many of the previous speakers alluded to this, that we think about the value that technology can add. And I think that really gets to this distinction between hype and hope and pragmatism of implementation. If we're going to build trust, we have to focus on value. Value for whom and value in which ways. I think we would all agree that technology can bring value for clients. There are many studies, I read one just a week ago in Kisumu district in Kenya that showed rates of successful malaria treatment completion increased from 9% to 59%. We've seen Uber ambulance services in Tanzania reduce maternal and infant mortality by 27%. Technology brings real value to people at a time, as Alan said, when they need it most. We also know technology can bring a lot of value to healthcare workers. And I think it is exceedingly difficult to be a healthcare worker these days. Medical knowledge, and in the 1950s, the doubling rate of medical knowledge in the world was 50 years. In 2020, it was 73 days. What that means is that a person who started medical school in 2010, by 2020, what they learned in 2010 would only be 6% of the total medical knowledge in the world. I would argue that a doctor with AI, with helping to digest information, helping to process information, which already happens today, be it through discussion forums, be it through newsletters, getting smarter about how we can help healthcare workers process the vast amounts of medical knowledge in the world today is absolute essential value. And then, of course, technology can bring value to health system administrators. And I think that is often where a lot of the hidden value lies, is in the administrative processes, reducing the administrative burden. And that is where I think we can really see, and some of the studies that are coming out now is really showing how this new generation of AI is bringing immediate value to the administrative processes of healthcare delivery, whilst we work on the regulatory requirements and the higher hanging fruit of clinical decision support systems and so on. The real question, I think, is what will it take for these good implications to be realized and bad implications to be avoided? And as Michael said, I agree with you that I think we will learn a lot and we will be wrong a lot and we will be humbled a lot, but that is a good thing because that's the process of scientific discovery. So I think to get this right, there are a few things we really need to focus on. The first one is the foundations, be it the fact that 1 in 8 people live in energy poverty, be it the fact that 2 in 3 people still live in data poverty, where the cost of 1 gig of data is more expensive than the total monthly transport costs of getting to and from work in low-income countries. That will not ensure the kind of access that we need to realize and have everyone have access to technology in a way that they will trust. When either of us, so that's the foundational part. We need to focus on the energy poverty, data poverty, and we also need to focus on digital skills. That is absolutely essential, be it from just basic comfort with digital technology all the way to the high-level expertise that is needed. Second, we need to focus on measuring and quantifying this value. All of us have had experiences with apps that we downloaded on our phones and within a week deleted because we realized they didn't bring value. Other apps we may use for months or years to come because they are so useful. We have an intrinsic sense, each of us as individuals and the clients, providers in the health system, of what does it mean when something brings value, and that value combined with it solving real problems, combined with familiarity of being able to use it because it's there, it's familiar, it is affordable to do so, is what will build this trust in the system itself. I firmly believe that technology, when it works really well, is invisible. We don't feel the technology, we feel the result and the impact of that technology. And lastly, of course, we need to focus on the fiduciary and the financial aspects. There are urgent questions that need to be answered around how the new technologies will be financed within the context of countries' health financing systems. Within the context of service delivery, regardless of what a country's health financing system looks like, we have to focus not just on the value, but on financing the achievement of that value and how we know when we've been successful and when we make progress in that regard. And then, of course, the governance aspects is absolutely essential. And it's a tightrope we need to walk between being neither overly careful nor under careful. And I think we are iteratively going to learn what that entails, how we can be successful. And I think if we do all these things, we can really unlock the value. And by unlocking the value, I fully believe that we will create trust in these technologies as they improve health and healthcare.
Great. Thank you so much. So many important things in what you just said, but I want to pick up on specifically around the point around digital skills. And Liam, you'll have an interesting perspective on this as both an academic and a clinician. During COVID, you recognized the significant increase in mistrust between patients and health systems, and that gap hasn't really recovered since then. So how can we effectively train health professionals to work alongside AI systems, build these digital skills, while ensuring that their critical thinking skills and their compassion and humanity remain intact?
Yeah, it's a good question. I think for me, the first thing to say on that would be that I think the next generation of health professionals, these are the teenagers, people in their early 20s, have grown up, many of them not knowing anything else. And I think it's the heads of institutions and medical schools and all the rest of it who need to do the catching up and be driven by their students' comfort and knowledge of digital tools and AI that they've simply grown up with. And they're well aware of its limitations, they're well aware of its strengths, but their fluency with not just digital tools, but the rapid development of new things is something that I think the higher, older generations can learn from. And so I think it's not really for people like me to sort of say, oh, well, I think we need to do this and this because we've got to teach our youngsters about computers. They didn't know a world without computers. So it's almost like we can give them a history lesson in trying to imagine doing this job with no digital tools whatsoever. And it would just be like, that's probably not going to be very useful. So I think the next generation can embrace these tools, and that's great. What I think is what it's up to people like us to do is to ensure that things don't get kind of carried away. We need the constraints. We need to ensure that as digital tools emerge and roll out, that they really are going to improve human health. And either they allow things to happen more quickly and with less input from humans, but with the same outcome, or they allow things to happen more cheaply, but with the same outcome, or they produce better health outcomes. And there you've got three things, all of which are worth doing. But to simply sort of embrace a digital tool because it's there is I think, the next generation know that that's not the way to go. They're well aware of the limitations. And I think you see that just in, it's an illustration of two things. So when you go on let's call it a shopping platform. I know there's many shopping platforms. Let's take Amazon. And you go on there, and it's based on your profile, it's recommending things you might be interested in buying. Or you go on Spotify, and it's recommending songs that you might want to listen to. And sometimes they're quite good suggestions. And sometimes it's like, there's no way I want to listen to Bruce Springsteen. Get out of here. And not again. And that's okay. People are used to the idea that sometimes these things help, and sometimes they're the opposite of helpful. But they're used to taking them into account in the complexity of their lives. And they're not expecting it to be the answer. If you bought everything that Amazon suggested you buy, and that's what you let that guide your shopping, you'd run out of a few things desperately, and you'd have huge stockpiles of things you never needed in the first place. No one would do that. No one expects these things to be able to take into account the totality of sort of human existence. And so I think the expectation is realistic. We sort of think, yeah, that's quite a good idea for a song. Oh, I've never heard of them. Let's try that song. Don't like it. That's okay. I wasn't supposed to like every song it suggests. And people are very used to that idea. And I think that comes into clinical care very much. And I think that judgment is inherent for particularly, I think, the next generation. I think they know it inherently, that these things are going to help. There's no doubt lots of examples have been given already of things that have undoubtedly helped. Having linked up computerized electronic health records that are available anywhere on any device is just fantastic. Being able to type in that you want to start a patient on a new drug, and the computer quickly checks what drugs they're already on, are there any dangerous interactions, maybe you need to adjust the dose, and if you do, it tells you how to do it, and tells you, even suggests the right dose. There's all sorts of digital tools that are just fantastic. Diagnostics, all sorts. But they all need to be taken into account in the sort of holistic way of the totality of that human being in front of you. And that's going to depend on their preferences, what mood they're in, what happened last year, whether they get one of their kids with them who's expressing a different opinion. There's things that there's no possible way any digital tool is going to completely replace. And I think it's embracing the digital age and AI. And yes, there are big advantages, and I think that we'll see big advantages, and we need to ensure those advantages happen around the world. But I think it's not going to replace holistic healthcare, for example, which is always going to be human-based because of its complexity and its uniqueness. When you're facing a patient with a terrible diagnosis, and they've got to make a treatment plan, and it's got to fit around their life and what they want and their preferences and all sorts of things, there isn't an algorithm to tell, there isn't one, because they're totally unique. There isn't a learning thing that's going to tell you exactly what's right for that patient. But I think most clinicians, and certainly the next generation, just accept that, are very comfortable with that idea. So we can gain a huge amount from digital tools, but we just need to take it into account. I mean, if you look back in the post-Second World War years in the UK, I was talking to one of my mentors who's probably going to die soon, they're so old. But anyway, they were practicing in primary care in the UK after the Second World War, and they couldn't get blood tests. So they had to do clinical care. So say you were trying to guess if someone was anemic. All you could do was look in their eyes and sort of make looking a bit pale, looking a bit dark, probably, maybe. And then they could suddenly get blood counts done. And this was a revolution. And it was a huge progress. And just one little thing revolutionized care. But it was still one step in a very complex array of humanity. And I think we see the same with really good digital tools and AI tools happening now. They can make a big difference in a narrow area, and we need to make sure they're well regulated and they're actually effective. But I think they're going to come into a complex human place, and that's going to move with time as well, very, very rapidly. So I think that having the human beings in charge of it on an individual level really matters. And I think that's where we're going. And I think the next generation are much more comfortable with that than my generation.
Very interesting, thank you. I'm going to turn to questions from the audience in just a moment, so get them ready. But I think I'd like to sort of pose what you were just talking about to the rest of the panel. We've had some really fascinating insights about where we are right now, but as we think about where we're going, I'm curious, as you know, we've talked about how AI and these advanced technologies may not replace humans, but are we going to get toward a place as technology improves diagnosis and treatment of patients? Is there a point in the future where patients may trust tech more than human providers, and should they? Alon, do you want to start on this one?
Yeah, so fascinating panel, and I hope, the audience is really taking in all of this richness. First of all, my wife might disagree that the shopping cart is too effective because the amount of crap that we've accumulated over the years, thanks to these algorithms, is quite embarrassing. But we are living in this new age, right? So think about it. In the last week, 2 Nobel Prizes have been awarded with much consternation by some sectors of this world, but to people who were seminal in advancing the space of artificial intelligence. And I think that is a significant thing that we should be thinking about. But I think that the theme that emerges here, and to your question, is we should be seeing AI as augmented intelligence, not artificial intelligence. And that's really what has echoed across this panel. It's a tool that increases our capacity as human beings. And earlier in the week, I was speaking to a colleague who's steeped in this space, and he was saying that where we should be looking for immediate low-hanging fruit is where we see this augmented intelligence taking care of the mundane, the laundry, the dishes, so that we can focus on the art and the creativity, right? And so what are the laundry and the dishes in the medical space? What are the laundry and the dishes in public health that will allow us to then not spend 4 hours a day, or in some cases, 1 day a week when we look at frontline health workers in rural South Asia, on paperwork, on aggregating information and reporting it upwards, but actually in providing patient care. So I think we're seeing these transformational changes happening around us, but as Marlies pointed out, we have to insist on value. Because that differential between, we're in the space where this is new, exciting, but the hype and the hope should not be conflated. We have to keep in mind that, first of all, there's AI and there's AI, right? There's probabilistic AI that's been with us now for almost a decade. There's over 1,000 AI medical tools that are in standard practice, that are CE marked, that are FDA approved, that are in the mainstream, whether you're talking about diagnostics or EMRs. And so AIs are very much part of our current daily existence. So we mustn't sort of conflate the brouhaha around Gen AI as being something that supplants the really important advances that probabilistic AI has made in this space. WHO actually has a guidance right now on the use of our AI tools for tuberculosis detection in chest x-rays. And that's based on examination of the evidence, that's based on the fact that it fills an important gap in the workforce. So we are seeing these things happen. But I want to come back to something Karen brought up earlier about this German study, because there was another study earlier this year in JAMA Oncology. Many of you might have seen it. It's this famous, you see 2 normal distributions where you have empathy and clarity of communication in how it's communicated in a blind way to patients, and patients grade whether they found the communication to be more empathetic and more clear. And there was a shift in the distribution where the AI responses were seen to be more empathetic and more clear. Now, more recently, another study came out in Lancet that looked at more carefully assessing the actual responses. So yes, they were very clear and very empathetic, and any one of us who has used an AI, a generative AI, to ask a question, those answers are not just clear, but they're often very authoritative. And if you walk away with face value, you might come away thinking, oh, this is phenomenal. I've gotten the right answer, let me take it. But this new study actually had clinicians go back and examine the meat of the responses. And about 7% of those responses contained information that would be harmful to the patient, and one of those responses would have led to the death of the patient, right? So it's a clarion call for us to be excited, to really think about integrating these systems, but also, as each of the panelists have said, we need evidence of impact, we need evidence of safety, and we need to ensure that humans aren't taken out of the loop, because we're not quite there yet. And I think that's a really important caveat as we pummel forward in this space.
Great.
If I can just jump in on a couple of areas. One is that just onto this, what I might call automation bias, but it's not exactly that in the context of a consumer or a patient reading the information. But I so agree with you, Alan. I think this is where critical thinking, understanding of the sourcing of the information is going to be so important as a skill for the whole world. And I think because the models can be trained to take on a persona that feels really accessible and authoritative. And if any of you have used some of these conversational tools, I think you've gotten a sense of that. As you constrain the models to make them more factual and grounded, they're less fun. So they're less likely to write a sonnet about your chemotherapy, but more likely to actually tell you the real source from the literature of what the randomized trial was. And so there's this sort of behind the scenes work is actively what companies that make and academic organizations that make these new AI model technologies are trying to understand is what's the right way to literally dial it. And I can't help but thinking about training physicians, like you're always trying to dial that. You can be wicked smart, but you also need to have a heart. And so there's a little bit of that kind of work happening. But I do think it's not a blocker in the sense of we shouldn't keep going forward, but it is worth all of us understanding, because when totally blinded, the models do come across quite empathetic. We published some work where we used something called standardized patients, which is used in training clinicians, and the standardized patient interacts with a doctor bot behind the scenes or with a clinician, the standardized patient, not knowing which is which, prefers the bot because it has this way of learning to be empathetic. So I think there's an important education, but also I think for makers of the technology, what is performance benchmark? What is a safety benchmark? What is the way that we will hold ourselves accountable to building models, but how should the whole industry and regulators hold the industry accountable? That work needs to get done. This is a little slightly off topic, but it's kind of come up in the theme, and it has to do with accessibility of the models. And so there are AI models, this general purpose AI models that are very expensive to run and energy consumptive and take a lot of, to train them, a lot of parameters, and to use them, a lot of tokens. There are also open source models that aren't behind a firewall from a company. And so there's some that are available. Like at Google, we have one called Gemma that's available for use. So they're becoming more accessible, but there are some that are still behind the scenes. But I think the important thing that I want to make sure you all understand is there's also a lot of work to make the models smaller. So to make large language models little enough that they don't cost so much to run, that they don't require so much data to train, that they can be run on a smartphone. And that is a future where these models become more accessible, not only because they're used by more places in the world, but because every person will have more availability to them. And again, completely know that the foundations aren't there for the whole world. On the other hand, smartphones and mobile technology is an entry pathway more than desktops or cloud computing. And so I'd say certainly for us, but I know for many other companies, the accessibility to the every person is really important, because the power and potential, the promise of extending affordable, accessible health, not just health care, to people as they have a personal, I'm sitting up here without my phone, I can't believe that. A personal, where's my agent? As they have an agent built into some technology in the way that we've gotten used to using apps in many parts of the world, the agent will be working with you behind the scenes, and that kind of gets to your question about when will people start to trust. I think, I don't know this for certain, but so I'm saying this as a person, not wearing my Google hat so much, but I see that where the world's evolving is in the way that my life changed when I got a smartphone and started having apps, and there was an app for everything. We're going to evolve to where the manifestation of these models is more like an agent, and it feels more seamless and behind the scenes for you, and it's calling the apps for you. So even if if the app is not something that you've valued regularly, but there's actually some good information in there, it's going to know to, I'm going to keep picking on the WHO, but to call the WHO for the algorithm of care, because that's the best place, but it'll do it more seamlessly behind the scenes and be less intentional than it is today. And going back to the beginning, that is why it's so important that we're really intentional about building these models, not only for accessibility, but for quality and for safety and for context.
Absolutely, thanks. Would anyone else from the panel like to pick up on this before we move to audience questions?
A quick thought from my side. You know, the question you ask is one that's been asked and written about very passionately in very different ways, right? There are folks who feel that AI is going to be, an agent is going to be our entry to healthcare, and there are folks who feel they're not smarter than a cat yet, and we should not be trusting them.
Than a cat, you said?
Yes, then we should not be trusting them with any healthcare. I'd like to come down right in the middle. And to me, when I think about AI, I think augmented intelligence is a good way to think about it. I also think about, again, coming back to value. When it comes to AI in health, it's really about the agency and insight that these technologies can bring, be it to a person who might not otherwise have had access to healthcare, who might start online and then go to a primary care facility, or be it a doctor who might be overwhelmed with the amount of medical knowledge that is available in the world. I think as long as that's our aim and that's our focus, is to create agency and insight, this question around should technology be used or trusted on its own, should there be a human in the loop, it is always going to be a mixed picture, because it really depends on the context. If I want to know whether my child who has diarrhea, I should take them to a health facility or call an Uber ambulance, or just make arrangements for care, when doing so is going to put my family in significant financial distress. Knowing when to worry and how much to worry, and that being an online interaction that we can reasonably trust, is an excellent health outcome. It doesn't mean there is no human involved. It just means that in specific situations, that is very context specific. Sometimes technology on its own might work when it comes to information, but should humans always be in charge of healthcare and decisions about healthcare? Absolutely. And I think as long as that focus on the agency and insight that it provides remains, that's when we'll see the most collective benefit.
Very
Maybe,
interesting.
Amanda, I would like to spice up the conversation a little bit, because there's
Please spice
too
it
much, too much consensus here. I think, first of all, I agree. It's great that we have this positive posture, hope behind the hype. That is clear. We've been talking about trust and values, for the last, 45 minutes. We didn't mention one word, which is responsibility and accountability, because the flip side of trust is responsibility and accountability. And again, yes, life changed completely with the emergence of smartphones and everything. Who were the greatest beneficiaries of that one? Who created the most shareholder value on that one? These were the hyperscalers, and on AI, it's the hyperscalers and NVIDIA. And the second largest winner on shareholder value creation in the US currently is an energy company, because it sucks up so much energy. So what I'm trying to say is this is still a hype. There is hope behind the hype, but there is not an individual business model yet from companies to really earn money with AI. Now, coming to responsibility in healthcare. That's why I say it is so embedded in our strategy, yet the core of our strategy didn't change human to human, and that our claim is committed to life. So it is a very powerful tool to do what we do anyways, because we are the trusted institution when patients come to us. And I believe there is a difference when we use data, for example. There's probably something in the public domain, and those things in the public domain, it would be great if they are curated from the WHO and so on and so forth. But I believe trust goes even further when we have our own network. We got 26 million patients. So whatever we do with the data, if you so wish, behind the firewall, because the knowledge and the improvement and outcome only comes because we curate the data, we annotate the data, we have the medical experts who can read those data, and then it may lead to a better clinical pathway on any disease pattern. Now that is where we also bear the responsibility and accountability when it ultimately comes to making a clinical decision in our network. And that's why we have this intrinsic motivation, intent, to really keep it at high quality. Because we also know that the technology can hallucinate, right? It can hallucinate to the point that it may have had an autocratarian tone or undercurrent. What is the quality of the data? What is the source of the data? Which population did we look at when we did a clinical study? Was it only, I don't know, what Europeans, German, male, white, yada, 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 or was it a different one? But if you have those institutions who maybe have, in brackets, their own data and AI and algorithms and pathways, and they start to exchange with one another. We can exchange our algorithms with Charité here in Berlin. We can exchange them with Mayo Clinic, with Kaiser Permanente in the US, and then gain even more insights on clinical pathways. And there today, and this is what I'm saying, this is a catalyst. This is what we're trying to do today with or without digital technology. We measure our outcome, whether clinical decisions are being better than before by technology. And this one is, that's why I said it is supercharged by that one. But we do have to work together and collaborate with, on the other hand, big tech, for example, or smaller things, with maybe a development ecosystem on platforms where everybody has his or her own part to play, but it will boil down to responsibility. And obviously the biggest impediment I currently see is more or less on the governance, on the regional regulatory governance, because this also, next to trust, is the most impediment to speed. If I look at the US, I have the feeling they innovate and then regulate. If I look at the EU, I have the feeling they regulate and then innovate. The EU AI Act, for example, is very innovation unfriendly. So at the end of the day, if you are a healthcare company, it is the responsibility we bear at the core, and we use this as a very powerful tool.
Let's come in on the data issue, and I think this is really important. So data arising from clinical care. is, as you say, it's complete. You can do the most amazing things with it. And we, in the beginning of the COVID pandemic, came up with a new idea, which was instead of us being given data, we'd take the analytical tools to the data, and we were given pretty free access to some amazing clinical data. And it allowed us to do things that we'd never been able to do before very, very quickly. And most importantly, because we were accessing the data where the data was stored securely, what this means is that every keystroke, every access, every reason, every person who accessed the data in any shape or form is all recorded. It's all auditable, you know. And what this did for me was really address this central concern of patients, that they're worried about their confidentiality, of course. They're worried about their privacy, but I think they're also slightly concerned about what their data is being used for. Balanced with, no one really expects you, if you ask them, no one really thinks you can run a health system without looking at any data. No one would ever expect any country to run a schools and education service without counting how many kids there are, or knowing how old they are, and maybe even knowing whether they can read or write, or whether they're doing well in their exams or not. So everyone expects us to be using data in a good way. At the same time, they're a bit concerned about their own data, but I think they're mostly concerned about confidentiality and security, which I think is pretty straightforward. And I think they're concerned about knowing what it's being used for. And I think what we have implemented is taking the analytical tools to the data, allowing fully auditable trail. You have to write down what you're going to do, you have to have protocols, you have to have analytical plans, you have to show that you followed them. And I think that's allowed us to sort of give that massive reassurance that not only do you know every single thing I'm doing to your data and you know what it's for, but you also know it's not moving around, no one else is getting access to it. And I think that really gives people the confidence to sort of allow researchers and clinicians to use their data. And I think that's where we should be moving to.
Yeah.
Lovely. Thank you. I promised the audience some questions. We're running low on time, so we'll take a few questions for the panel now. Here in front.
So much. My name is Kana Halic Gordic. I'm here on behalf of International Federation of Medical Student Associations, FMSA, as liaison officer for medical education issues. So our organization actually conducted a survey on digital health, which showcased global gap in digital health education worldwide, with many students as future healthcare professionals feeling unprepared for digital transformation of healthcare. So I would like to ask you to reflect how we can, with international collaboration and initiatives, help to bridge that gap, ensuring that future healthcare professionals worldwide are equipped with necessary digital skills. Thank you.
Take two more questions here in front.
Thank you very much. I am Budi Setiawan, Chief of Health of UNICEF based in Nepal, Kathmandu. So Nepal, we have 7 out of 1,000 adolescents try to commit suicide in their lifetime. So this is related to the point you made, Karen, with about the crisis management. Because I think this is where we interest, because they could have gone to a platform and tried to find solutions, but I think the crisis management component is also key to be able to connect these children in need immediately to the healthcare system. The other one is also for online. I think the one thing also we realize is a lot of cultural sensitivity we need to also use when it comes to mental health-enabled AI or AI-enabled mental health approach. And I think this is something that WHO has a role to make sure the standards in terms of the algorithms to be also be culturally adaptable, because the context of suicide in South Asia will be different with the context of suicide prevention in Europe. Thank you.
Thank you. One more question. There in the back. Oh, sorry.
No? Jacob Peterson at London School of Hygiene and Surgical Medicine. I just, of course, every any new technology, there's a lot of private investment, and there seems to, there's a risk. I think there could be a certain amount of overselling what the new tools can do, although they already do lots of powerful things. I think maybe there should also be maybe some caution for health researchers, healthcare practitioners, to to think about what exactly these systems are doing. That they are mining data that are produced by humans and will have flaws that we build in in a way in that way. So there are also, of course, examples of patients that might be denied some treatment, or people who get profiled by the police or something because the underlying data that was the technology was trained on had built-in sort of maybe that the people they generated the data were racist to some kind or to a point. So it's just maybe some among all the hype and the hope, there should also be some critical approach to this, I think. I didn't hear that in the panel discussion, so.
Great, thank you. Who would like to start?
I could give some overall.
Go ahead, Lou.
Oh, go on then.
Please go ahead.
I mean, on the overall, I think answer to possibly all three questions. I think if we think back 30 years ago, we sequenced the human genome, and I've got a cover picture I think it's from Time magazine, I can't remember, and it says, "This is it, health has changed forever." And what we've seen is, some great progress was made, and some genetic tools have come into widespread use, and it's helped us understand some basic processes, and we learned a fair amount, and I think it's improved the world on the whole, and I think AI is where we're at now. Is AI going to radically alter the rest of human life and change healthcare forever? A little bit, yeah, a bit. And it's going to have some benefits, and we're going to learn some lessons along the way. What I think we can learn from this sort of genomics revolution is, number one, that we need to evaluate things properly, and are they really going to improve human health, rather than just be a fancy new tool. But I think the other things we can learn are that technology advances in genomics were almost the benefits were almost entirely in the richer world. And the lower resource settings are almost completely missed out of the benefits. Lots of reasons, one around technology itself, one around education, but thirdly also because the data itself, the genomic data we have worldwide, is hugely lacking for most low resource populations. So our knowledge of the genomes across Africa, for example, is so limited compared to our knowledge of the genomes in Europe, for example. And so I think we can learn a lot for how we've got these fantastic breakthroughs with AI and digital technologies. And I think we can learn a lot by looking back and thinking, how do we do it better? And we evaluate things to ensure they're actually going to impact on human health, and that cuts the hype. And we've got to really ensure that the whole world benefits, and not the people who really don't have the most to gain. The people who have the most to gain from better technology and better healthcare are the people in the low resource and low resilient settings. They've got the most to gain, and that's where we need to be focusing our efforts.
Lovely, thank you.
I'll take all three in rapid succession if I could, and then we can come back to it. One, share your passion for training the current and next generation of healthcare workforce in digital tooling, including AI. We're doing some work in the space. Excuse me, I'm sorry. It's pretty early, but we'll definitely would love some input. So if you want to come see me afterwards, we can talk about how we're trying to use platforms like YouTube to make information training available. We also have tooling through something called Grow with Google, which is a digital skilling platform, which is free training and certificates. So depending upon the interest and needs, we want to be helpful to do our part. And I do think that even if you're a digital native, there's special stuff that has to be learned. We're working on making our tooling, our technology available to local organizations so they can help to interrupt people in crisis, in addition to what we try to do on the platforms, because it's it's going to be multiple parts along the chain. So if you also want to come see me, our mental health team is here actually at this conference, and I can get you connected with them. There's somebody sitting right over here also. And so I'd love to hear more about how you all are thinking about it, because again, it's not just technology, it's humans, and then the technology in humans' hands. And we've written a lot about equity in the models and the challenges of especially in Western medicine, of so much racism inherent in the way that research was done, the way algorithms are written. We call it the HEAL framework, H-E-A-L. We've recently published in Nature about it, but we have it on our website. Would love input. We think it's a beginning of a journey. It's not the end. There's so much work that has to be done because the information into the models affects the way it answers questions. And we red team and try to do adversarial testing to see how it's going to respond. But it's just a beginning, and there's just a narrow way that we're able to do that still in the world. So I'd encourage you to give us some feedback on how we could do better. Thank you.
Great.
Yeah, fantastic response, Karen. I think the other additional thing is thinking about competencies, right, for not just health workers. And I think Google has done a really amazing job in developing the global Google developers community, right, to enhance the skill set of the people out there who are developing systems in response to the needs of ministries of health and governments. And I think that's one segment of capacity building that's necessary. WHO is actually working right now on what we call a digital competency framework, which is looking to actually define what are the skill sets across people, practitioners, and policymakers needed to be functionally competent in this 21st century with AI and other emergent tools. And I think there's a concept of we have a concept of hygiene, for example, across the room, right? During COVID, we promulgated this idea of hand washing and basic common sense practices that would improve our resilience to health insults. But I think that same idea of digital hygiene needs to be developed. From a very early age, how do we teach children, young people, adults to function effectively in an era where they need to be responsible custodians of their data? They need to understand the implications of engaging with a digital ecosystem. And I think we're not quite there yet. Even among digital natives, there's a lack of appreciation of the far-reaching consequences and risks that are associated with data breaches and data compromise. So I think we have some ways to go, and it's why I think WHO is so intrinsically passionate about youth engagement. We have a youth council and really making sure we're listening to and integrating the voice of the future generations and the current generations who are growing up in this into global and national policy. So I think that's really important. But I want to come back to something, Karen, you said about small models and not just the environmental and access issues that small models bring to the table, but it's this idea that you bring up from Nepal about localization and fine-tuning of models to the context in which they're going to be used. And that's really, really critical. It's something that I think as we look at the equity and access to AI, small models are going to have a major role to play, because that's where we get it into the hands of people living in rural communities, into the hands of frontline health workers who need access to these tools as part of their arsenal of tools to respond to this stuff. I just want to end with one example of a program in South Africa that began 15 years ago, sending text messages to pregnant women during the course of their pregnancy, just under the premise, as the government of South Africa said, access to information is a basic human right. So for free, they have been sponsoring now messaging being sent out to pregnant women. A few years ago, that system transitioned to being an AI-driven chatbot. And the overwhelming response by people to have a partner in their pregnancy journey, that even though they're reminded every day, I am a chatbot, I am not a human, I will answer your questions and provide you information. Women are sending pictures of their newborn babies to the chatbot. They are empathizing with this bot that has accompanied them through their pregnancy journey. But because that bot has been trained and localized to the South African context. And so I think hopefully that's the kind of tool we'll begin to see used more and more across the world, whether it's for suicide prevention, improving mental health, or supporting women through the challenging time in their life course.
Great.
And maybe to take the complete other end of the spectrum, from an individual baby and sending a picture to a chatbot, quite a lasting image, Elan, that you will leave with me, is on the other end of the spectrum, we know that, or the IMF estimates that 64% of a country's wealth is its human capital. And health is an essential part of countries' human capital. So as we think about AI for human capital, the reciprocal is also true. Human capital for AI. We are not going to be collectively successful in realizing all this potential if the skills are not there to build what is needed. So just to say that I very much agree with your point that I think digital skills is an urgent priority at all the levels throughout the spectrum so that this potential can be realized, and there are humans who can be in the loop, skilled humans who can be in the loop to ensure that we squeeze the best possible value out of this technology for human capital.
Certainly. Great. Well, we just have a few minutes left. Rapid fire style. Is there anything we didn't talk about today? Anything that you'd like to leave with this audience? Anything that struck you from this conversation? And we're going to work together to keep this to 3 minutes.
I'll be very quick, because I think that the key thing that I've heard, not just in this panel, but over and over again, is this idea of invisible, right? When technology is partnering with you, embedded, ambient, we heard these different terms, but I think that's the destination, right? Where you're not thinking about the technology. It's not interrupting your workflow. The last thing a clinician or a frontline health worker in a difficult context needs is something that adds burden and that disrupts their way of doing things. What we need is that augmentation that almost anticipates what you need and supports you in that journey. So I think as we work towards, these are early days. Again, I said it earlier, we're impatient optimists. We want all this stuff to work seamlessly right out the gate. But these are early days for some of these Gen AI technologies. And we have to be thinking about the vision of what we want to see at the end. And that is this embeddedness, this almost invisibility of the technology that helps us in doing what we're doing so that we can not be doing laundry and dishes, but focusing on art and creativity.
Great.
4 years ago, I walked into my primary care office and they just installed an ambient AI system. And I will just say that was exactly the transformation that you've just described, where a conversation with one's doctor, which is a sacred and safe space, converted from a desk and a computer and lots of typing to a conversation on 2 lazy boy chairs, sitting and talking, giving both the doctor and I the safe space to have a difficult conversation. But it wasn't about the technology at that moment in time. It was about how the technology enabled the human connection in healthcare to work so much better.
Yeah.
Great.
I would say with what I said at the second sentence, we probably underestimate the short term and overestimate the long term. I think, Liam, there's maybe a difference to genomics because it's a general purpose technology. It really cuts across as an enabling, very disruptive force across everything. So the 2 Nobel Prize winners, and they come from this pedigree. One was about protein folding.
Yep.
So the power it could bring to science, which would have taken years and years or not even thinkable of analysis, was driven by this one. So the biggest impediment currently is really skilling, reskilling, skilling, and this will prevail. I talked to an MIT professor the other day on computer science, and he said that all his students are actually in trauma because everything they learned is already old. And what should they do? And we will not be able to, stop the progress of technology, from look at, first of all, machine learning, now LLMs, now the power of LLMs, now we're talking about general models, we talk about convolutional neural networks, and we all have to keep pace with this one, and this is not going to stop. So it is, at the end of the day, up to institutions and individuals how to deal with it. Trust, again, comes with responsibility. I would love to see open foundational models, like in a Linux model on computer OS. And then we got to see how responsibility and trust pave the way so that at the end of the day in healthcare, it is to the benefit of patients.
Great. I'm getting nervous looks from the management team
I think
here.
that was I think that was a perfect ending, right? Because
I think so.
technology should be in the benefit of patients, and that's
Thanks,
what we're all
Karen.
here for. So thank you.
Last word?
No, I think that's right. I think what patients want, the healthcare providers and practitioners, patients are looking to them to use all these tools appropriately, and putting faith in those tools. But the patient, so it is up to the providers and practitioners to use this whole array of tools, but to build that knowledge and build that expertise that they can use them appropriately and they can use them to do things better. And I think that's where patients are relying on that layer of provider to really navigate the whole system. And I think we're getting there.
Great. Well, thank you so much to everyone in the room.
Very good.
Take care and enjoy the rest of the conference.